बंद ही कर दो कि जब चल नहीं रहा तो क्या करना है। इसमें कुछ गड़बड़ हो रहा है, चल नहीं रहा है ये इसके थ्रू। So, good afternoon, everybody, and apologies for the delayed start due to some inadvertent technical region. And we'll be talking about a very, very important disorder, that is thyroid disorder, about thyrotoxicosis, which is extremely relevant from a pediatric endocrine perspective and which has got significant implications in terms of diagnosis and management. So we'll try to cover this about various aspects of the thyroid disorder. So we'll start off with this case, 17-year-old girl with neck pain who had a high FT4 and low TSH, was advised methimazole, and she did not have any eye signs or goiter. Now, this is a common presentation, and unfortunately, this child was started on methimazole. While if we look at the clinical picture, it was less likely to be Graves' disease, and in this scenario, a possibility of thyroiditis should have been considered. So, a thyroid scan was done, which showed a reduced intake in that perspective. You can watch on YouTube. So very importantly, therefore, it is that we should really look at nuclear scan individuals who have got a feature of thyrotoxicosis, especially if their FT4 levels are not very high, if they do not have an eye sign, if they do not have a goiter in that regards. All of you can go and have a look at our website, learning.growsociety.in. You can go and have a look at our web portal, which has got a lot of learning resources which are there. Look at our fellowship courses which are there in that perspective, and the courses including the courses for fellowship and PG courses as well. You can also attend our many of our free series which are there in terms of the lecture series, journal clubs, and our publications which are accessible, and also in terms of our app which helps in terms of diagnosis and management at the right time. So today we're going to talk about thyrotoxicosis. I'll touch base initially about the overall physiology. Then Dr. Alapan will talk about the etiological aspects. And then we will have again discussion about assessment management, and Dr. Sandeep will take up forward from some of the Q&As in that regards. So TRH is produced via the hypothalamus, which acts on its receptor to produce TSH action, which then acts on the thyroid to produce T4, which is basically a prohormone. The T4 is converted using monodehydrogenase 1 to T3, and it can be inactivated via the monodehydrogenase 3 into reverse T3. So this T4 is also largely bound to TBG. Only 99.7% is bound and very small amount is free, and T3. So ultimately it is the free hormones which are responsible for the action. And this then acts on the thyroid receptor to cause decrease in the TSH levels. So anybody with thyrotoxicosis, the first thing which should happen is a decline in TSH, followed by a rise in T4, which is the second scenario, which should happen in that regards, and finally T3 will rise. However, under certain circumstances, we can have a rise in T3, which may happen because of increased activity of monodehydrogenase, which results in increased conversion of T4 to T3, especially in iodine deficient conditions, and this is known as T3 toxicosis. So that's why T3 becomes the important investigation. When we discussed last time about hypothyroidism, we said that T3 has got very limited or no value, but T3 is very, very important from a thyrotoxicosis perspective in that regards. So from a pathophysiological perspective, the problem could be in the form of a thyroid receptor stimulating antibody acting on the TSH receptor, which is the classical Graves' disease, in which we will have a goiter, we will have an eye sign, and that's why the size will increase from that perspective. So this will be increased production, decreased TSH, high levels of T3 and T4, and the scan will show the uptake will be on the greater side. On the other hand, if there is a damage to the thyroid gland because of various causes, the preformed hormone, and we know that around 2 months store is there in any gland. This is the largest gland in that perspective. It stores for 2 months. The release can cause transient thyrotoxicosis, which can then improve. Now, this damage is associated with decreased TSH, high levels of T3 and T4, and there will be absent uptake on the thyroid gland. Rarely you can have a problem in the thyroid, in the hypothalamic region, where you can have a TSH producing adenoma, which can cause this scenario. There will be detectable TSH with high T3 and T4. Anybody who has a high FT4 should have zero TSH. If the TSH is there, we have to start thinking of other possibilities like TSH receptor secreting adenoma, which is extremely uncommon in children, or a rare possibility of thyroid hormone resistance in this scenario. Now, thyroid scan will give you a picture of absent uptake in the scenario of thyroid damage and increased uptake again on a TSH dependent scenario. So etiologically, most common cause is TSH independent, and this is usually associated with the antibody, which is Graves, or rarely thyroiditis, less common in children, but also an important consideration as in the first case. We can also have a solitary thyroid nodule, which can produce thyroid hormone. The amount of production is lower here, and usually it is a subclinical scenario, or we can have a multinodular goiter. These are more likely to be present in elderlies. Rarely in children, we can have McCune-Albright syndrome, in which you can have increased production because of the GNAS activation, along with multiple other abnormalities like precocious puberty, fibrous dysplasia, cafe au lait spots, and other scenarios in that regards. So TSH receptor antibody plays an important role in that perspective. TSH dependent causes are associated with detectable TSH because of TSH adenoma, and in periphery you can have a resistance to the thyroid hormone. So now we will move forward in terms of the overall scenario of the further evaluation and how the etiology plays out. So we will now have Dr. Alappan, who will talk about the etiological aspects of thyrotoxicosis. Over to you, Dr. Alappan.
So I will start with the etiology part of the thyrotoxicosis. So the knowing the etiology part is very important in terms of management of the thyrotoxicosis. Thyrotoxicosis, or the excess of thyroid hormone, could be of two types: TSH independent part, which is because of either release of the thyroid hormones, as we can see in cases of acute, chronic, and subacute thyroiditis. Here, there will be no presence of any goiter, and if you do a thyroid scan, there will be no uptake in that scenario. Or it could be due to the excess production of thyroid, excess production of the hormones due to Graves' disease, most commonly. Other causes like toxic nodule, multinodular goiter, or rarely McCune-Albright or TSH receptor antibody activating mutation can cause TSH independent thyrotoxicosis. The other possibilities of thyrotoxicosis are TSH dependent, like in cases of TSH producing pituitary tumors, or rarely thyroid receptor beta defect can present like this. Both of these conditions will present with goiter, and there will be increased stressor uptake uh, when we do thyroid scan. Moving on to the most common cause of thyrotoxicosis in pediatric population, that is Graves' disease. We all know that TSH acts on the TSH receptor to produce T4 and T3. This T4 and T3 binds with TBC, and it further acts on the thyroid receptor. So here it is an autoimmune condition in which there is an antibody production stimulating the thyroid TSH receptor, causing increase in the thyroid gland as well as production of the excess amount of T4 and T3. There will be signs like eye signs will be present in cases of Graves' disease, as well as presence of goiter will be there in cases of Graves' disease. So the major pathophysiology here, the antibody is produced, and it produces much more T4 and T3, which will cause suppression of the TSH. So decreased TSH, increase high T3, and high T4 is a hallmark of Graves' disease. We have to do all the investigation like TSH, T3, and T4 in this scenario because there is a condition also known as T3 toxicosis. In iodine deficiency state, there is increased amount of production of the T3 in comparison to the T4 due to the high monodeiodinase 1 activity. It is leading to a condition called T3 toxicosis. So we should always look for all the parameters TSH, T3, and T4 when we are evaluating a patient with Graves' disease. Now moving on to the etiology of the Graves' disease, this is an autoimmune condition, and usually it is associated with other autoimmune conditions like type 1 diabetes, celiac disease, or adrenal insufficiency. Rarely, some syndromes like Down syndrome and Turner syndrome could be associated with Graves' disease. Moving on to the next disease, the TSH receptor activating mutation. Here, there is a activating mutation in the TSH receptor leading to production of T4 and T3 and also increase in the thyroid gland. This is an autosomal dominant condition, and the closest differential diagnosis of this TSH receptor activating mutation is a infant with or newborn with thyrotoxicosis in a mother of a the mother present with a Graves disease. But in that scenario, there will be a transient rise of thyrotoxicosis in patients. And if we can't stop the treatment of the neonatal thyrotoxicosis beyond 2 months or more, then we have to always keep an eye on the possibility of TSH receptor activating mutation, which will be present both in cases of neonate as well as in the mother. The treatment of choice here is surgery. Moving on to the thyroid nodule. Thyroid nodule is nothing but just localized swelling of the thyroid gland, and this gland producing excess of thyroid hormones, causing increase in the T4 and T3 and suppressing the TSH level. But here, the production of the thyroid hormone is not that significantly high. So usually this is present like a subclinical thyrotoxicosis where T4, T3 level are normal or higher normal and TSH level will be suppressed. If we do a scan, we can see a hot spot on the scan, and the treatment of choice is here in pediatric population is surgery. Moving on to the toxic multinodular goiter, here the number of nodule is more than one, and here will be also production of the excess amount of T4 present. It is not very commonly seen in cases of children and seen mainly in cases of elderly. The presentation is also similarly like subclinical thyrotoxicosis seen. The surgery choice of treatment is surgery and radioactive iodine. Moving on to the next part, the thyroiditis. We all know thyroid is a large gland present in our neck, and it produces thyroid hormones. Not only that, it can store hormone for the acute conditions like up to 2 months or 3 months. So, if any cases when there is a destruction of the thyroid gland, these hormones are released, and this causes a picture of hyperthyroidism leading to increase in the T4 and T3 level, causing suppression of the TSH. This destruction of the thyroid gland causes no uptake in the thyroid gland in thyroid scan, and there will be no signs of Graves like eye signs are not present in these cases. The major causes of thyroiditis are like antibody mediated seen in cases of chronic thyroiditis, where it is a painless swelling which is self-limiting, or it could be due to some viral illnesses causing subacute thyroiditis, uh, in which there will be thyroid gland will be extremely tender and there will be rise of the inflammatory markers like CRP and ESR. It could be an acute condition like any bacterial infection causing thyroiditis. It is usually known as acute thyroiditis. It is an extreme painful situation, and it has a propensity for recurrences due to a connection with the pyriform sinuses. Antibiotic and surgeries are the treatment of choice. So if we compare the forms of thyroiditis, the etiology of lymphocytic is autoimmune, where subacute is due to the post-viral illnesses, and acute cases are due to the pyogenic bacterial infections. Onset will be very short duration in cases of subacute, while lymphocytic is usually having a gradual onset. There will be an extreme or severe level of pain in cases of acute thyroiditis, while lymphocytic will not have any pain. CRP levels will be, or inflammatory markers will be high in cases of subacute and acute thyroiditis. Ideally, if we see the course of the thyroiditis, the lymphocytic usually have an initial hyperthyroidism phase, and followed by it can precipitate hypothyroidism, while the rest other two, it is subacute cases, it is self-limited, usually responds to treatment especially very well, while the acute cases are usually recurrent. That means there is ideally a pathway between pyriform sinus and the thyroid, which causes multiple episodes of bacterial infection in the thyroid gland. So we have to uh, cut this connection between this pyriform sinus and thyroid gland. If we go for the FNSC, we can see there is lymphocytic infiltration in cases of lymphocytic thyroiditis, while it is granulomatous infiltration in subacute, while in acute cases of thyroiditis, the infiltration are neutrophilic. Treatment, antibiotics and surgery are the choice in cases of acute. Subacute is usually self-limiting, but if pain is persisting or symptoms are not getting well, so we can go for a short courses of steroid therapy in that scenario. And in cases of lymphocytic, we can go for the symptomatic treatment like beta blocker is the treatment of choice. Moving on to the TSH dependent thyrotoxicosis, the important one, first one is the TSH producing pituitary tumor. This TSH producing pituitary tumor produces much more amount of TSH, which acts on the TSH receptor and produces T4 and T3. As we all know that T4 and T3 with TSH have a log linear relationship. That means if your T4 is high, T3 is high, the TSH should be undetectable. But in these cases, there is high T4, high T3 with a normal or higher normal TSH level is seen. There is excess production of the alpha subunit of the TSH that is diagnostic and differentiating from the thyroid hormone resistance. So detectable tumor, and this tumor detectable TSH with a large pituitary tumor because of the late detection have a picture of a TSH dependent thyrotoxicosis. There is no role of radioactive iodine or ATD in this case, as giving ATD to these patients could further lead to increase of the size of the pituitary tumor. So the treatment of choice is somatostatin receptor ligand and beta blocker. Moving on to the last and the rarest part of the thyrotoxicosis, that is thyroid hormone resistance. Here also, due to the resistance of the thyroid receptor, there is an increase in the amount of T4 as well as T3 with normal or higher normal TSH level. The associated conditions with thyroid hormone resistance are deafness and ADHD. We can go for a high dose of T4 or beta blocker, or sometimes some other compounds like TRAC can be tried in cases of TSH hormone resistance. Thank you.
Thanks a lot, Alapan, for summarizing this part very well. And we've discussed a lot about etiology. We'll now talk about our assessment. So the key questions in thyrotoxicosis are, is it really thyrotoxicosis? What is the status, whether it's a TSS dependent or independent thyrotoxicosis? What's the cause and how do we treat? So as discussed, thyrotoxicosis has effects on every part of the body. So the most common symptom that we see as children, or of course, the pediatric patients will come us with, is a thyroid swelling and a protrusion of eyeball. But there are other symptoms like tremor and anxiety because of sympathetic hyperactivity. That is something which is there. On the long term, it can have an effect on the bone, causing low bone mass. Tachycardia, atrial fibrillation are rare in children, but can happen in extreme scenarios, particularly if they are presenting to us as a thyrotoxicosis storm. There could be a high output failure if the heart pumping becomes too much. Fever, unexplained fever is a common presentation which we have to look at. And these children are tall, but along with that, they have an advanced bone age. So they have a compromised height from that perspective, and hyperdefecation may also be there. So most common symptoms that we will encounter is usually eye signs along with a thyromegaly, and then weight loss, tremor, and sympathetic symptoms are also very, very important. So thyrotoxicosis should be considered in any child who has got significant weight loss, who has got frequent motions, tremors, eye signs, periodic paralysis, and polyuria. Now, while I'm emphasizing on eye signs and that being a marker of Graves' disease, we should understand is that more patients of thyrotoxicosis without eye signs will have Graves' disease as against thyroiditis. So just the absence of thyromegaly, just the absence of eye sign does not exclude Graves' disease. It makes the chances of thyroiditis a bit more. That is the only thing you have to remember about. So fatigability, worsening of school performance, and it's also been associated with myasthenia gravis, which becomes important. Now, in very, very acute scenario, if the thyroid is uncontrolled, especially if somebody goes for surgery, or if there's some radioactive treatment is there, the patient goes into what is known as thyroid storm. In that scenario, there could be a refractory thyrotoxicosis resulting in cardiac failure, hyperthermia, and that could be a life-threatening condition for which we need to be really worried about, because otherwise the patient will go into a comatose state and there could be a high chance of death from that regards. Now, when we talk about thyroid assessment, we know that for thyrotoxicosis, as I discussed earlier, we need to look at both FT4, TSH, as well as T. Anybody whose TSH is thyrotoxicosis there, TSH should be low and T4 is high. T3 is the last one to be raised, but sometimes because of T3 toxicosis, your T3 may be disproportionately high. So thyrotoxicosis, you have to look at all of the three parameters together. Do not ignore T3 because then you won't know whether it's a subclinical thyrotoxicosis which does not need treatment or T3 toxicosis where treatment is definitely required. Now, once we know that this is thyroid the issue, the next issue would be what is the underlying cause. And for that, we need to look at both FT4 and TSH together. Anybody who has a high FT4 should have a zero TSH or an undetectable TSH. This is classically a case of thyrotoxicosis. If FT4 is high and TSH is detectable, that is meaning that there is either a TSH receptor adenoma, which is very, very rare in children, or there could be a thyroid hormone resistance, which also is rare. So always repeat that scenario from that perspective. Now, another important thing to look at is when should you think of thyroiditis versus Graves' disease? And in that regards, the thing that you can look at are antibodies. TPO antibodies is not a very, very good marker, but it will give you a clue towards thyroiditis. There will be no eye sign of goiter. It's a milder disease. The FP4 levels are usually less than the double of the upper normal range. So if you have an upper normal range of 22 picomoles per liter, this will be somewhere around 25, 30. While in Graves, the levels may go up to 50, 55. They are much, much higher. So very high level will suggest Graves because ultimately you don't have that much thyroid to be released from the gland from that regards. While if you have a TSH receptor stimulating antibodies, you will have other features like eye signs and goiter. Remember that the antibodies which are acting in the eyes may be different completely because they are working on different antigens, but often they coexist and they will be more severe levels are typically above double the upper limit of thyroid hormone and the uptake on scan will be high. And then you have to treat them with antithyroid drugs. So clearly, if you have a much more severe onset, you have got eye signs, you have got goiter, your FT4 is very, very high, you should think of Graves' disease. While FT4 is not that high, there is no goiter, there are no eye signs, there is no bruit, it is more likely to be thyroiditis. Especially if there is tenderness in the neck, start thinking, as Alapan said, about subacute thyroiditis. And if it's extreme tenderness, then you should think of acute thyroiditis or a pyogenic infection in that regards. Usually, we would not recommend radionuclide scan in everybody or the TSH receptor antibodies, but if you are in doubt, then you can look at these tests to get the final diagnosis in that regards. Now, anybody who has got no goiter and the onset is below 1 year of age, the likelihood of Graves' disease becomes extremely unlikely, and then you have to think of some other cause, especially if there is no eye signs as well. TSH receptor antibody is a very good test. It tells us about the autoimmunity status. But what you need to remember is the TSH receptor antibody may be stimulatory and inhibitory. And the antibodies we are measuring is actually an immunoassay. It is not a bioassay. So while TSH stimulatory immunoglobulin TSI, which is a bioassay, is a better marker of thyroid production or increased activity, it is extremely expensive, takes time, it's not routinely available. So we measure TRAB, and if TRAB is positive in a characteristic clinical scenario, in that setting, you can consider basically that this is more likely to be Graves' disease than anything else. So this is an immunoassay in which you are competing to the TSH binding, and this can be both stimulatory or inhibitory from that regards. While for bioassay, you have to actually look into particular cells of cultured thyrocyte cells where TSH antibodies are going to increase the thyroid production. This is something which is extremely expensive, not easily available. But TRAB antibodies are now being used as the first line to differentiate Graves versus thyroiditis. So the chances of needing a scan is less. So if you are wanting to distinguish and you do a TRAB is very high, no need to do any further. If your TRAB is negative and your suspicion of Graves is more, then you can do for scan. So the chances of needing a scan, which is more difficult, also exposing to radiation, is now less with the use of TRAB antibody in that regards from that perspective. So thyroid scan, we all know we can use iodine 123, but most people now are using technetium 99, and especially if there is no eye sign, goiter, and TRAB is negative. However, one condition where a scan should be done always is if there is a solitary nodule. If there is a solitary nodule, you want to make sure whether it is a hot nodule, a warm nodule, or a cold nodule, because that is going to determine the need for FNAC and the risk for malignancy. So that becomes extremely important. So you may find no uptake on thyroid scan, which is thyroiditis. You may find diffuse uptake, which is Graves' disease. You may find a toxic hot nodule in which you have got uptake in the nodule, and the rest all area there is no uptake. Or you can find the MNG, or really you can find a warm nodule in which there is uptake in the nodule, but the surrounding areas also have got certain uptake in that regards. Thyroid ultrasound has got limited role, but it may be helpful in terms of characterizing your thyroid nodule if it is there from that perspective. Some people talk about vascularity as a marker of increased production, but that's not something which is extremely well proven. So it's not a good tool to differentiate between thyroiditis versus Graves' disease in that regards. So nuclear scan is ideally the best test, but we may also do TRAB antibodies if that's easily available to you. You may avoid these if there are clear-cut goiter or eye signs or the FT4 is extremely high. If the uptake is increased, this is more likely to be a solitary nodule. If there is a toxic MNG, you will find multiple nodules. If there is diffuse uptake, this will be like Graves' disease. If the uptake is decreased and there is tenderness, this is more likely to be a subacute thyroiditis. If there is no tenderness, this is going to be a chronic lymphocytic thyroiditis. So based upon the level of FT4 elevation, based upon the size of the nodule, you can be able to identify that. Now, management option, basically, we know that for Graves' disease, the only options is to block the production using either anti-thyroid drugs, radioactive iodine, or surgery. This is a persistent fluctuating course. Lymphocytic thyroiditis, you all need to do is to just tide over the crisis, give beta blockers, and they will be remission, but they may develop hypothyroidism. Subacute thyroiditis may require steroid course also because the pain is quite high and it may remit over 2 to 6 weeks. Acute thyroiditis, as Arapan said, could be a marker of a sinus, a connection between the thyroid and the gastrointestinal tract, or the piriform sinus. And this needs a excision because otherwise they will again develop these abscesses on multiple times. Drug-induced thyroiditis may also happen with amiodarone. In that case, you can use beta blocker or methimazole, and there could be remission or relapse in that perspective. So Graves' disease, the options include the medications. This will, of course, have a lag phase because the medicines are going to stop the production now, and you will have to wait for 6 to 8 weeks for the preformed thyroid, which is already there. It is not going to affect the course. So some people used to say, okay, I use a higher dose, I block it, and then I replace with thyroxine, then I'll be able to change the course. No, studies have not shown that block replacement or thyroid doses will change the course of the disease. So you have to continue as the block therapy only and not block replacement, which is something which we don't want to recommend. It can, however, be used across all ages. And we talk about radioactive iodine. Earlier, the cutoff was 10 years. Now people talk about 5 years as a cutoff in that regards. Very importantly, radioactive iodine should be given only after stabilization because if we give it at an early stage, you have a risk of causing thyroid storm. And if somebody has an eye sign, which is an active eye disease, you have to be very cautious because it may exaggerate and exacerbate that in that regards. Now, usually the remission rate is high with radioactive iodine, but sometimes we have seen that you require up to 2 doses, rarely 3 doses as well, and it should be done after 5 years. Many centers consider it as a primary treatment of choice after 10 years of age. 5 to 10 years, it's a borderline scenario. Surgical management is going down. Typically, it is done mainly for toxic nodule. It should also be done after stabilization. It's a good one, but it requires a high surgical skill and somebody who has a large goiter, which in adults is defined as size more than 80 grams. That is a scenario wherein surgery is clearly recommended. So there's a lag phase of antithyroid drug of 6 to 8 weeks, can be done at any age. There is a good chance of remission around 20 to 40%. It depends upon the gender, the age of onset, prepubertal versus postpubertal. Pubertal have a higher chance of remission. Girls have a better chance of remission. So those scenarios will be there. And we have to be cautious about the idiosyncratic reaction which may happen. And radioactive iodine, we have to be very cautious about ophthalmopathy in that regards. So the current scenario in pediatric, I would say most of us will be starting with antithyroid drug, radioactive iodine as the second line, and surgery reserved for very, very rare scenarios in that perspective. We discussed about thyroid storm, which can be a ICU problem or an emergency problem. In that case, you need to do many things. You cannot rely on the antithyroid drug because that's going to take a few weeks for the effect to happen. So the most effective immediate agent is to use iodine. which will act via the Wolff-Chaikoff effect. It's going to inhibit the thyroid production. So earlier people used to use Lugol's iodine, which may not be available. So the iodinated contrasts which are available can also be used in terms of in that regards. We also start methimazole at the same time to have so as to achieve outcome, but very importantly use steroids, which will inhibit the conversion of T4 to T3, as well as beta blockers, which will give you a much better sympathetic protection as well as benefit in terms of peripheral conversion is there. There could also be cardiac failure, for which digoxin is the drug of choice, and hyperthermia may also require some cooling in that perspective. So beta blockers, anti-thyroid drugs, steroids, and iodine, particularly sodium iodate at 100 milligrams per day is what is recommended in terms of this treatment, and this may be an acute emergency with a very good outcome from that regards. Beta blockers, we need to remember that if somebody's thyroid functions are extremely high, you may actually have a very decrease in half-life of the beta blockers. So you can use longer acting preparations, and you can use longer acting preparations given more frequently. So normally we say Ciplar LA, we use 40 milligrams twice a day. Here you can use it up to 6 to 8 hours. That will be like 3 to 4 times a day. Somebody with a respiratory problem, you can use metoprolol or atenolol, which are more site specific from that perspective. Now, antithyroid drugs are basically thionamide, which are structurally similar and they inhibit the process. You can use carbimazole or methimazole. Carbimazole is a prodrug. It is converted into methimazole. So we generally prefer methimazole. It has got higher potency, but if somebody is on carbimazole, you can continue with the same medication. Remember, these are pretty much structurally similar compounds like prednisone, prednisolone. So you may have similar side effect profile, particularly the idiosyncratic reaction, which can happen in that perspective. They're going to inhibit the iodination, they're going to inhibit the TPO activity, and that's why they're going to improve that. Propyl thiouracil is another drug which is going to be effective. It was a good drug which was being used earlier, but now with the advent of idiosyncratic hepatic dysfunction, which has been reported, and with the chance of hepatic failure, we do not use PTU. The only use of PTU is in the first trimester of pregnancy, where it has been used because it's got lesser teratogenic effects as compared to methimazole. Do not use PTU in children. That is a FDA black box warning also in that regards. They compete with TPO, and some people talk about immunomodulation, but as I said, they are not being shown to change the course of the disease in that perspective in that regards. So methimazole and carbimazole basically are similar. PTU is slightly different. PTU, the dose that we start off with carbimazole and methimazole will roughly be 0.5 to 0.6 milligram per kg per day, and then we can come down gradually. 1 milligram of methimazole is actually more potent from that perspective, and there is a hepatic effect which is idiosyncratic for PTU, while it is more dose related to the methimazole and carbimazole in that regards. Very important effect which we have to be very cautious about is with regards to agranulocytosis, and this typically happens in the first 100 days of treatment. With methimazole and carbimazole, this typically happens in the initial phase and it may be dose dependent, but we have seen idiosyncratic reaction in which the counts can become very, very high because of the ANCA positivity which is there. So these drugs, two things you have to worry about. One is the liver dysfunction and one is the sore throat. So if some patient on these agents complains of sore throat and fever, you have to immediately stop the medicine, get a complete blood count done, and then go from that in that perspective. There are also risk of birth defects, which are more common with the thionamides, the carbimazole, methimazole, lesser with the PTU from that perspective. So it should be avoided in the first trimester. As I said, the only role of propyl thiouracil is in the first trimester of pregnancy in that regards. Now, initiation doses are dependent upon your FT4 levels. As I said, if FT4 is above 50, which is common in Graves' disease, you start at a higher dose of around 0.5 milligram per kg per day. Somebody with 35 to 50, you start with 0.3, and less than 35, you can start with 0.15. So this gives you a better idea as to what dose you start off. So generally speaking, if you talk about a 30 kg child, you're talking about doses somewhere around 15 to 20 milligrams if the levels are very, very high, 10 to 15 milligrams if they are borderline, and 5 to 10 milligrams in smaller scenarios from that perspective. Always get a baseline CBC to look at any possibility of dyscrasias. ALT levels are also known to be high in thyrotoxicosis. So that will give you a good clue. You have to give it, usually you can give it once a day or twice a day also. If somebody develops sore throat and fever, immediately they should stop the medicine, get a CBC done and contact you from that regards. If somebody develops jaundice, somebody develops itching, then also they should contact us immediately from that perspective. Usually we repeat the levels after 6 to 8 weeks and then 3 monthly. Remember, there will be a lag time. Your FT4 will come down, but TSH will take time to rise. So don't wait for TSH to rise because that will be too late from that perspective. Your target is to keep FT4 in the high normal range and TSH in the low normal, 0.5 to 2. But remember that in the initial phase, if your FT4 has become normal, reduce the dose to half. Most people continue the same dose, but if you do not reduce the dose to half, you will have hypothyroidism very quickly. If your TSH is high, FT4 is low, definitely reduce the dose very significantly. If your FT4 is low and TSH is normal, which may happen because of the lag phase, still you have to reduce the dose. On the other hand, if you have both normal, then you can reduce the dose by 50%. Otherwise, you can reduce by 75%. So typically, we start with around 20 milligrams and make it 10 milligrams once the level becomes normal. If the TSH is low, then also you have to be concerned. And if that FT4 is high, that is the only situation where you have to increase the dose from that perspective. And FT4 gives you a better clue rather than TSH in that regards. Mild adverse effects include rash, urticaria, and pain. And often, if you give them the antihistaminics, they will improve with that perspective. Neutropenia is the one which we are really worried about. Vasculitis and high liver dysfunction could be other causes of concern. Severe defects include agranulocytosis and liver failure, which we are worried. Most adverse effects happen in the 3 months of therapy, and they're usually dose dependent, especially in younger children. If somebody has a fever with sore throat, I'm emphasizing it time and again, in that situation, you should stop it. If the ALT is more than 3 times the upper limit. Now, here comes the importance of the earlier level. If your ALT is 70 already, then it going to 90 may not be relevant. But if it was 30 and now it goes to 90, then you have to stop the medication, which is very, very important. We have seen some patients who can have mucosal allergic reactions, skin reactions, where you might also have to discontinue in that regards. And generally, when you say you're stopping methimazole, carbimazole will also be stopped. And there is also an overlap in the adverse effect profile between both carbimazole and PTU. So you have to be very cautious because then you have to think of alternate curative therapy. If somebody develops a fever, get a CBC done. If CBC shows a ANC level neutrophil count below 500, then this means you have to stop it and you cannot start again because then it will be very risky. You may consider giving a colony stimulating factor course. 500 to 1500, which is quite common. Here you wait for some time till it becomes 1500 and then you can start considering. More than 1500, it's not a cause of worry. You can continue the treatment. So neutrophil count is extremely important in that regards. Now, remission, as I said, is less common, particularly for prepubertal male individuals with large goiter, chances around 15 to 20%. If it's a small goiter and TRAB is negative, the chance of remission is more. Typically, if remission happens, it will happen by around 1.5 to 2 years. Beyond that, the chance of remission is less. And also remember that if there is a male gender, which I said, there is a chance of remission in that regards. So if you're on a very, very small doses, 2.5 to 5 milligram, the goiter size has come down, TRAB is negative, you may consider, okay, now we can stop the treatment and see how it goes. But there is always a chance of relapse. Typically, 30% of them will relapse. So we typically say 1/3 will remit. And out of the remaining, you may also have a recurrence in 1/3. So you have to be very, very cautious from that regards. Usually happens within 1 year, but can happen after many years. So you have to follow them up very clearly. If the chances of remission again is high, treat with methimazole. Otherwise, you should think of radioactive iodine as a definitive treatment. The radioactive iodine, as I said, some people talk about primary treatment also, but usually most consider it for relapse. It should be avoided during active ophthalmopathy. That can be a risk, or somebody has a large goiter. Beyond 80 grams, you don't expect a response in that perspective. And somebody who's below 5 years of age. Aim is not to reduce the thyroid level. You have to ablate it. Aim is to completely kill it. because if you leave some thyroid tissue, there is a risk of developing malignancy subsequently. So induced hypothyroidism, we use ablative doses. So you control the thyroid function with anti-thyroid drug, stop for 3 to 5 days. You should not do the radioactive iodine therapy without stopping. So this will allow the thyroid uptake to happen. Dose, as I said, will depend upon the pubertal status and other scenarios. So let the nuclear medicine people decide that. But the aim is to ablate the thyroid, not just to reduce its function. And then you follow up the standard radioactive precautions, which are there in terms of the isolation, in terms of urine collection, in terms of being away from pregnant women and children. These factors have to be there. And you have to be cautious that they do not develop hypo or hyperthyroidism. Sore throat is quite common in that regards. After 2 months, typically hypothyroidism is there. You will start thyroxine treatment. And if there is a relapse, you may need to do 2 doses. I've seen patients who needed 2 to 3 doses as well. So we have to be cautious. Malignancy risk for thyroid cancer is only there if it's a very low dose. So we don't use that dose, we use a higher dose. Second malignancy also, there is no risk. And if somebody is less than 5 years, we should be very cautious. That's why it's not indicated below 5 years of age. So the management is that if there is no response to methimazole, child is less than 5 years, the only option is surgery. While if it's more than 5 years of age, size is big, consider surgery. Size is less than 80, consider radioactive iodine. So most will come into that. 80 grams is a very, very big goiter, which is unusual in children. If there is response to methimazole and there are risk factors, then you will probably continue till around 3 years. If there is no risk factor, then wait for remission. Otherwise, you continue it for 5 years. Now, these are not very clear cut, but these are some of the guidelines which suggest that. And I won't say they are very evidence based, but what they are saying is that if you have a very high initial FT4, if TRAB is persistently high, large goiter and male continue for around 5 years for remission. But of course, if these situations at 2.5 your TSH is high, why will you continue? So it has to be an individualized decision also from that perspective. If there's no remission, then you start going in the other arm about definitive treatment, and relapse also you have to go for the definitive treatment from that perspective. So we have tried to cover a lot about these aspects of thyrotoxicosis. We will now be moving towards the next aspects about Q&A. Dr. Sandeep has created some very interesting questions. So you have to answer the Q&A questions and we'll take them one by one in that perspective. Yeah. Yeah, Dr. Sandeep.
Thank you, sir. So after this thorough discussion about the thyroid, hyperthyroidism, we'll move on to the question and answer section. First question, 11 years old girl. She presented with features of thyrotoxicosis with she had goiter and severe ophthalmopathy. Free T4 was high, 45, and TSH was undetectable. She was diagnosed as grave disease, subsequently started on antithyroid drugs for 5 years. Subsequently, she went into relapse. There was a remission followed by relapse. Now, what will be the next line of management?
What do you want to do here? This is a girl who has grave disease with remission, which is there. How big is the goiter?
So goiter is quite big. Also, there was a severe ophthalmopathy, sir.
Severe ophthalmopathy and goiter. So I think two clues are already there. We will now like to look into in terms of what the audience is saying in terms of the answer. So you can put it up in the Q&A or the chat option. So you can put the answer in the Q&A. There is, I think the answer is coming now. Yeah. So Dr. Aisha is talking about radioactive iodine. Do you agree?
Sir, the ophthalmopathy is severe, so we should avoid radioactive.
We should avoid surgery, the treatment choice. It's a large goiter also from that perspective. So I think this is very clearly does not require radioactive iodine. It would definitely benefit from the use of surgery would be the only treatment of choice. Yeah.
So surgery is required, and we'll now move to the next question.
Okay.
So, 6 months old infant presented with features suggestive of, thyrotoxicosis. There was a history of grave disease in mother, and neonatal thyrotoxicosis was detected at day 4 of life during screening. Baby was started on anti-thyroid drugs, and even after, at the age of 6 months, baby was still having features of thyrotoxicosis and poor control.
So this child is on anti-thyroid drugs, but still the control is not there. So what is the usual half-life of these TSH receptor antibodies?
So usually it is 2 weeks half life is there.
So
So
generally by around 2 to 3 months, we expect this Graves' disease to neonatal Graves' disease to settle down. So what could be the possible reason that this child born to a mother with Graves' disease, quote unquote Graves' disease, is having persistent requirement? So was the TSH receptor antibody done in the mother?
so it was not done in the mother, sir.
So there is no TSH receptor antibody documented in the mother. So this is a clue. So are we dealing with Graves or is it something else? So you can all put in the Q&A part. This is an interesting scenario. We did discuss a bit that there's a condition Alapan talked about is the TSH receptor stimulating mutations. When the mutation in which there is an autonomic activity of the TSH receptor, in which it's autosomal dominant condition. So antibody in the baby, Dr. Aisha is saying, or genetic testing will also be there. So this is most likely an autosomal dominant TSH receptor
Activating
activating
mutation.
mutation. And how do you manage them?
So treatment of choice is surgeries in this.
Because you can treat for life, they will need, but otherwise surgery for both mother and child, both will be benefiting from the
Yes, sir.
surgery in that regard. So we can consider antibody, but 6 months is a bit late. We could have done it by 2 months, 3 months. So in this scenario, maybe a genetic study will give you.
Awesome. We'll now move to the next question. 10 years old boy had features of thyrotoxicosis. TSH was undetectable, FT435, and on examination there was a solitary thyroid nodule. Nuclear scan was suggestive of hot nodule. What is the next further treatment?
So this is a good question. So you have got a child with a toxic, solitary toxic nodule. The question is what will be your next treatment and what will be your final treatment? These would be the two
Yes,
questions
yes.
probably in terms of this. So we'll request all to give an answer to that. So what would you like to do? Whether you'll go for radioactive iodine, whether you will go for anti-thyroid drug or whether you will go for surgery. These are the only three
Yes.
options. So let's see what the audience is answering. So Dr. Iman had mentioned about TSH receptor mutation, which was correct. Now, Dr. Aisha has mentioned about surgery. So surgery is definitely the treatment of choice for solitary nodule, but should be done after stabilization. So surgery after stabilizing thyroid function. What will be the problem if you do a surgery right now?
So, since patient is already having features of thyrotoxicosis, patient will end up in thyroid storm, sir.
Yes, so definitely we should be cautious. We should not be doing that in that perspective.
आगे move नहीं हो रहा.
So we should do surgery after stabilization. So carry on.
Next question. 15 years old girl, features of thyrotoxicosis. FT4 is 28 millimole per liter and TSH is 0.01. There was mild tenderness in the neck, no goiter, no eye signs, and ATP was positive. So, what is the most likely diagnosis based on the clinical features and examination?
So this is a girl who doesn't have any eye sign or goiter. And importantly, what is the FT4 level? What is your normal level, Dr. Sandeep?
In this patient, the upper normal limit was 22, sir.
So it's within the double the range and there is no goiter. So as I said, here we are thinking more in terms of a damage rather than an increased production. And tenderness also will give you a clue. So Dr. Raj Lakshmi is saying thyroiditis, which is the correct diagnosis in that regard. So I think Hashimoto thyroiditis, if we consider tenderness, if it's very severe, subacute thyroiditis. So both options will be there. Which simple test will give you a clue that this is a thyroid inflammation.
CRP we can do.
CRP or ESR, we see ESR up to hundreds in this scenario often. And if it's very high, you may give a short course of steroids.
So chronic lymphocytic thyroiditis and treatment is beta blockers, that is supportive treatment.
Do not give anti-thyroid drugs.
16 years old girl, she had Graves' disease diagnosed case. She had eye signs, goiter. Started on antithyroid drugs, methimazole. After 3 months of treatment, the FT4 became normal, but TSH was still low. So what is the next course of action?
So this is 3 months after initiation of treatment. So we discussed about those scenarios to what should be done. So in this case, what you're saying is TSH is low, FT4 is normal. So what will come down, what will become normal first?
So T4 will become normal first, and TSH will take some time, sir.
Yes, so that is important. So we should reduce the dose. And we talked about around say 50 to 75% reduction in dose because getting FT4 to below normal level is very, very significant. So Dr. Raj Lakshmi, we agree, we have to reduce the dose by 50 to 75%. Dr. Iman is also saying the same thing. Dr. Aisha, 2 TSH after 3 weeks, 2 after discontinuing, we can do that. One other question which has come up about solitary nodules, shall we continue antithyroid medication and not go for surgery? But how long will you keep? So this is the toxic nodule. You cannot keep on giving for life because it's not going to go up. In adults, radioactive iodine can be given as an option. In children, we do not use radioactive iodine because then you are giving a low dose radiation exposure to the remaining thyroid. So that's why surgery is recommended. So otherwise, lifelong radioactive these drugs will not be a good option.
So in this case, we have reduced the dose.
Yeah. So reduce the dose by around 50%.
11 years old boy, a known case of Graves' disease, on methimazole 0.5 mg per kg per day since last 1 month. Suddenly had fever and sore throat, and TLC, ANC was basically for 410 per cubic millimeter. So how will you further manage this patient?
So this is the most dreaded complications. Of course, the treatment had been stopped, of course, in this scenario, and then you got the TLC done. So what will we do? Shall we start on PTU? What is the audience suggesting? So what will you suggest, Dr. Sandeep?
So in this case, we'll stop antithyroid drugs. We will treat this patient with antibiotics, and we'll go for granulocyte colony stimulating factor.
Yes, and you should avoid using any antithyroid drug here because that could be a problem and there can be a big issue from that regards. Another question is for Grace, can we continue antithyroid and not go for surgery? We can. If the patient is on low dose of this thing, there's no issue, then you can continue. So we should stop the drug, treat that, consider GCSF, the count is very low, less than 500 ANC. I said that you should go for never start in that regard. So you have to treat like any other ALL patient. So febrile neutropenia, Dr. Aisha is mentioning.
13 years old boy, a case of Graves' disease. On examination, there was large goiter. However, there were no eye signs. Free T4 was quite high, 55, and TSH was undetectable. Thyroid was quite large. It was 90 grams. Was started on antithyroid drugs. There was no remission even after 5 years of treatment. What will be the next approach?
So this is the large goiter in which we are having persistent thyrotoxicosis. I think it's too large for the drug to work on. So what could be the option? Dr. Iman is talking about surgery. So clearly surgery is the recommended treatment in this scenario.
Yes. 10 years old girl presented with thyrotoxicosis. Free T4 and T4, T3 and T4 were increased. TSH was detectable, and alpha subunit of TSH was also found to be increased. What from this all scenario, what is the most likely diagnosis?
So this is a very, very unusual scenario. You've got a detectable TSH with high FT3 and FT4. We said only two possibilities are there. One is a TSH adenoma and second is thyroid hormone resistance. So what does the alpha subunit tell us about? We didn't discuss about that. So that's why we...
Alpha subunit of TSH is basically a marker of increased production of TSH basically.
Yes. So no, increased production of TSH is there, but it is increased abnormal production of TSH, which means you're producing more alpha than beta. So that's why this is more indicative of a tumor. So TSH adenoma, that would be there, not TSH resistance. Yeah.
So from this clinical scenario, it is a case of TSH secreting adenoma, and in this patient we advise MRI hypothalamic pituitary region and managed with long-acting somatostatin receptor ligands and beta blocker for symptomatic.
Do not give radioactive iodine or antithyroid drugs because otherwise the lesion will become much bigger. These are very big lesions. So this could be a big, they may need surgical intervention also, but that should be done only. They will need surgical intervention basically, but only after SRL because SRL will decrease the size, but not to a great extent. So ultimately they will need surgery, but this should be done only after somatostatin receptor ligand. Do not, it's extremely unlikely at this age group, typically occurs in older individuals.
So fact checks, true and false. Thyroid function test should be monitored in infants born to mothers with Graves' disease on day 1 and day 3.
Yes, you can just say yes or no. Okay. So you should monitor at day 1, day 3, and day 14.
Sir, methimazole is first line of treatment for grave disease in children. Yes or no?
Yes.
Yes.
So day 1, Dr. Rajlakshmi is asking if somebody's TRAB is very high, 3 to 5 times the upper limit. We recommended day 0 or day 1, whatever. You can call that because they may develop graves very quickly. Within the first 3 days also, they may develop graves. So there are guidelines which suggest that if TRAB is below the 3 times the upper limit, you may skip the day 1 sample, do it at day 3. Otherwise, if you don't know the status, then day 1 becomes important. Yeah.
High T3, T4 and detectable TSH suggest of TSH adenoma or TSH thyroid hormone resistance. Already discussed.
So I think this is very clear. This is clearly the case. Yeah.
Chronic lymphocytic thyroiditis presents with goiter, eye sign, and increased uptake on nuclear scan.
So how many people agree with that? We have goiter, eye sign, and increased uptake. So this is CLT, chronic lymphocytic thyroiditis, or Graves? No. So Dr. Iman, Dr. Raj Lakshmi are saying no. This is more likely to be a Graves disease-like scenario.
Consider surgery in children with large goiters, more than 80 grams. True or false?
And who are not responsive to medications. So I think that is the caveat
Yes.
you should add.
Yes.
So you should consider surgery because radioactive iodine is not going to help out.
Thyrotoxicus with eye signs and goiter is most likely due to grave disease.
Yes. So Dr. Aisha is saying yes. So I think this is very, very clear. The message is very clear. Dr. Rajesh is also saying yes. रुक जाओ, मुश्किल है.
Reduce methimazole by 10% once the TFTs are normal on ATT.
So shall we reduce it by 10%? Or we should continue the same dose? No. So we should decrease it by generally 50%.
Low dose radiation is used for radioactive ablation in Graves' disease.
Yes. So for radioactive iodine, do you want to use lower dose or a higher dose? So yes, Dr. Ayesha is saying no, we need a much higher ablative dose. We want to finish the thyroid gland. We don't want to leave it anything to grow further.
Maternal Graves' disease with fetal tachycardia needs escalation of maternal antithyroid drugs. True or
Yes,
false?
that is an important scenario. So if the mother is having uncontrolled thyroid, baby is having tachycardia, then whether we give something to the baby or we give something to the mother. The first question, of course, is treating the mother to control the thyroid level. That will help you out.
Will increase the maternal antithyroid drug doses.
And that will cross the placenta also and may also help out.
Toxic nodule treatment of choice is radioactive ablation.
This is a very important message, and we discussed this also. So, do we do radioactive ablation in toxic nodule in children? No. So, below 18 years, surgery is a treatment of choice.
Thank you very much, sir. That was the last question.
Okay, thank you. Thank you. So, thanks a lot, Dr. Sandeep, for this wonderful questions which you had prepared, and they have really covered a lot of this. We had a very interactive session overall, and we again apologize for the delay in start because of some inadvertent reasons which were there. And you can all go and have a look at our website, learn.doctorid.in, explore our books and our application in that perspective. So we will now look into if there are any particular questions which are there. If not, we will close the session, and thanks all of you for